My name is Danielle Beharie. I'm one of the fourth-year OB-GYN residents. In the specialty of OB-GYN, we require 4 years of residency after medical school. I'm in the fourth of that. I'm the chief of the hospitalist service here at Methodist, so any OB or GYN consults, they kind of run through our team. A hospitalist is basically the OB-GYN care for the patients that don't have their own primary care OB-GYN here within this facility. So anyone who comes to the ER or any consults of any patients that are here within the hospital without a provider already in the Methodist system, we'll take care of them while they're here throughout their stay. I also carry the ER pager for the OB-GYN service, so anything that comes through the ER, any assistance that's needed throughout the day, I'll be the first call for it. Today I got here at around 6 a.m. We rounded as a team, kind of went over our list of patients, hospitalist patients for the day, and went over the cases as well as just the overall flow of the day and our to-do list as a team. We have a benign gynecology team as well as an oncology team. We interact together all the time. We bounce ideas off of each other, like, hey, what kind of cases are you doing? But they kind of just operate with our gynecologic oncologic surgeons, and then we do the benign service.
Posterior, anterior, you're going to have the rectangle, but it's your, so then you tag them, so you have tag them up, tag them down.
Our most complicated patient is about 29 weeks pregnant. She has COVID pneumonia as well as sickle cell, so we're trying to coordinate care with the primary team, the pulmonologist, infectious disease team, to do the best for her, as well as manage her obstetrically and make sure that she's on the correct course in terms of where she should be in her pregnancy and that the baby is developing well. I plan to go talk to one of the high-risk obstetrical doctors with my attending, Dr. Habde. The attending is a physician who's already completed residency, board certified, and they're basically in charge of our learning and making sure that we're taking care of patients and learning to the best of our abilities. I think that it's great for patients to be at a teaching institution. The good thing about students and residents is that we're continuously learning. It keeps our attendings continuously learning, and medicine isn't stagnant. Things are changing, evolving monthly, daily, especially as we can all see firsthand. So being around learners really forces everyone to continue to learn and improve patient care. I'm originally from South Florida. OB is something that I was exposed to most of my life. My mom worked as a labor and delivery nurse throughout my younger years and is a women's health practitioner now. So it was always something on my radar. I was interested in medicine, and obstetrics was something I always thought about. But once I got to medical school and actually got to do the rotation, I really appreciated the diversity that the specialty brings. One day you can be in clinic, you can do some deliveries, and you can be in the OR all within the same day, and that's kind of what I really liked. As well as the fact that you are doing a specialty that you can actually build a relationship with your patients, because you're at least friends for a year during the pregnancy, and patients generally stay with the same practitioner for a while, so that's why I like the specialty. I plan to be an OB generalist because that's going to provide me the variety as well. And so I'm in the process of looking for jobs. Today we're going to see a robotic-assisted laparoscopic hysterectomy. This patient has abnormal uterine bleeding, so kind of heavy menses, and she desires to be definitively managed from her heavy menstruation. So we'll kind of have a camera, we'll do everything from the console. I'll be assisting one of my previous chiefs, actually, who's my attending today for the surgery. As a resident, my responsibility is to get the patients ready in terms of pre-op, make sure the consents are done, the history, physical, basically everything that's going to run smoothly throughout the day. Once we're in the operating room, same thing, make sure that the patient is positioned properly because there are risks with poor positioning of patients, and then I can assist on the surgery, either on the console or laparoscopically. We've moved the patient from pre-op to the OR. Right now the patient is about to be intubated. This is an aerosolizing procedure, so with the current pandemic, we're now waiting outside of the room basically until all the air in the room recirculates. So no one's in the room except for an anesthesiologist who's intubating. Minimally invasive surgeries, the patients are able to go home. They do better in terms of pain management. We're able to do the same surgery without a large incision, so pain is better. They're able to ambulate and mobilize a lot quicker. Overall, especially our patients being women, do prefer smaller incisions than big, large ones along their abdomen. But there are a lot of benefits in general. I do work often on the actual Da Vinci console. We learn how to assist before we get on the console, but by the time we get to a 4th year where I am, we feel pretty comfortable performing our normal gynecological surgeries, commonly hysterectomies, salpingectomies. We did a pretty great case. It was as expected, and now she's off to PACU. She'll recover in one of the other rooms and ideally go home this afternoon. We generally go back in the afternoon, check on her, make sure everything is still going to plan. If there are any changes in the plan, make sure that she is progressing as expected. In terms of our cases for this afternoon, they've been canceled. We've had multiple patients present today with fever. Of course, everyone does get tested preoperatively for COVID, and they're scheduled pending a negative test. And when they present with a fever, we're unable to operate on them, which both affects them because now they have another diagnosis, but two, it also delays the care for their original surgery too. We're constantly rearranging the schedule if their preoperative testing is coming back positive and having them quarantine. We'll have to do our part and try to stay home and distance and practice the best hygiene that we can so that we can curb this pandemic and at least get control of what's going on. Unfortunately, I don't think we're going to be able to eradicate it immediately, but at least if we can try to decrease the amount of people who are affected by it, then we can curb it and better take care of our patients. We're definitely doing all that we can to both provide good care to our COVID patients as well as our continued excellent care to our non-COVID patients. If there's any concern or anything you still need to see your doctor for, I definitely recommend doing it. Keep up with your maintenance care. I just checked on the patient that we operated on this morning and she's doing great. She's having minimal pain. She's already been up walking and ready to try lunch. So meeting a lot of her milestones and planning to get home later today.